So this is Dr. Amy DeVosta from the Division of Adolescent Medicine and Gynecology at Children's Hospital Boston, and this morning's lecture topic is amenorrhea. The goal of today's discussion is to be able to differentiate between the normal and abnormal patterns of menstruation, for participants to be able to formulate a differential diagnosis of amenorrhea based on the history and exam findings, to plan the appropriate evaluation through laboratory studies or radiography, and to develop a management plan for common causes of amenorrhea in adolescents. So in order to understand abnormal processes, we first have to understand what normal development entails. So for most girls, the average age of thelarchy or breast budding is around age 12. Over the next year or two, peak height velocity in the growth spurt occurs, followed by menarche. And as you can see here, there is typically a 1 to 1.5 year period of time between menarche and ovulation beginning to occur. So menarche occurs during Tanner stage 3 to 4, after that peak height velocity and growth spurt. The mean age for menarche in the United States varies by race. For white Americans, it averages around 12.5 years of age. For African Americans, 12.1 years of age, and for Mexican Americans, in between. However, these numbers are influenced strongly by such things as family history, stress, body fat, exercise, and other chronic diseases as well. Haynes reported between 1999 and 2004 that menarche, the age has truly declined over the last 100 years or so. So if you were born before 1920, the average age of a young woman going through menarche was around 13.3 years. However, for women born between 1980 and 84, the average age had come down to 12.4. This is likely due to many processes, some environmental, some related to nutrition, but the age seems to be more stable currently over time. In terms of a normal menstrual pattern, the normal cycle length for an ovulatory cycle ranges between 21 and 35 days. Blood flow usually lasts for 3 to 7 days. Lengths more than that are considered to be excessive. A typical blood loss is around 30 to 40 cc's per cycle, which averages up to about 10 to 15 tampons or pads per cycle. However, adolescents and women are notoriously poor reporters of blood loss. Most women tend to overestimate blood loss during menses. Now that we understand normal patterns, now we can define what abnormal patterns are. So delayed development means no breast development, no breast budding at all by age 13. The true definition of primary amenorrhea varies depending on which textbook or article you're reading. Traditionally, most have quoted an age of 16 as being concerning for primary amenorrhea, but menarche at age 15 is already 3 standard deviations above the mean, so I would argue that being concerned for a girl who's not yet had periods by 15 is appropriate. It's also important to pay attention to the normal progression of puberty. So remembering back to our earlier figure, typically it takes 2 to 2.5 years from the onset of breast budding to menarche. So if you have a girl who's taken longer than that to achieve menarche, that's also someone I might be worried about. Secondary amenorrhea refers to periods that have started and then stopped. Again, textbook definitions usually quote a range from 3 to 6 months without menses as being concerning. I would say that any adolescent who's concerned about their lack of a period has a reason to be concerned, and I always try to exclude pregnancy for those patients. So where can things go wrong with this process, and where do we worry about issues happening? So starting up at the top, up at the brain, problems with the hypothalamic pituitary axis can cause issues with periods. So one of the most common is simple immaturity of the hypothalamic pituitary ovarian axis. That's responsible for those anovulatory cycles that occur for 1 to 2 years following menarche. Anorexia and bulimia can interfere with normal menses. So can high levels of stress, high-intensity exercise, and other chronic illnesses, particularly those that are associated with malnutrition. CNS tumors or history of radiation to the brain commonly interfere with periods. More rare things include pituitary infiltration or Kallmann syndrome. Also, issues with high levels of prolactin also interfere with normal menstruation. This can come from a pituitary adenoma, abnormally secreting prolactin, as an appropriate part of lactation and breastfeeding. High prolactin can occur related to certain medications and drugs, particularly the antipsychotics, and hypothyroidism also can stimulate high levels of prolactin. Moving down a bit, either over or under production from the thyroid gland also interferes with normal menstrual processes. Down in the pelvis, the adrenal glands can cause issues with having regular periods, whether that's from congenital adrenal hyperplasia, Cushing disease, Addison disease, or rarely tumors of the adrenal glands. The ovaries themselves are very common causes of issues with menses. Ovarian failure from gonadal dysgenesis, such as can occur with Turner syndrome. Chemotherapy or pelvic irradiation obviously can cause issues with failure of the ovaries to work normally. And autoimmune disease is another common cause of ovarian insufficiency. Tumors also can interfere with ovarian steroid production, and hyperandrogenism, such as occurs with polycystic ovary syndrome, is another common cause of irregular menses, both primary or secondary amenorrhea. Reproductive tract issues commonly can cause issues that are related to primary amenorrhea. Most of these are obstructive processes, so things like an imperforate hymen or vaginal septum, vaginal agenesis, or other obstructive congenital anomalies can all prevent periods from starting at a normal age. And lastly, being an adolescent medicine physician, I always have to go back to pregnancy and reminding people to rule that out as a potential cause of a young woman not having her period. So in terms of a diagnostic approach and how to figure out at what level problems are occurring, it involves your typical history, evaluation of growth charts, physical exam, and appropriate laboratory studies. So in terms of history, the most important information is typically regarding pubertal development. Is your patient someone who's never started puberty? There's been no signs of breast budding, no growth in height, or is this a young woman who seemed to be going through puberty at an appropriate time and then stopped along the way, perhaps never achieved full pubertal maturity? Getting a history of stress from this young woman, whether academic or physical. A sexual history. Is there any possibility of pregnancy for this young woman? Information about her exercise and eating habits, particularly looking for a mismatch between activity level and nutritional intake that would cause an ongoing energy deficit. Family history, so information about when mother started her period, when sisters started their period, other gynecologic history that might point you in one direction or another. A review of systems, very important, particularly focused on gastrointestinal, neurologic, or endocrine systems, and medications that the young woman might be taking that could interfere with these processes. Physical examination includes a careful review of the growth charts, calculating the percentage of median body weight that your patient is at, and really looking at these growth charts gives us clues to the diagnosis. So if you're seeing a young woman who's been losing weight over time, you may be more focused on evaluating for eating disorders, celiac disease, or inflammatory bowel disease. Conversely, patients who seem to be gaining weight over time, you may be looking for thyroid disease, Cushing syndrome, or polycystic ovary syndrome. Failure to grow in height is often associated with things that interfere with proper nutrition. So again, Crohn's disease, celiac disease, or other endocrine processes that interfere with normal growth. Tanner staging is very important, so evaluating the young woman to determine how far she has made it through the pubertal process. Just as a quick reminder, Tanner stage 1 means no pubertal development has occurred. There's no breast budding. There's no pubic hair development whatsoever. At Tanner stage 2, there's some small amount of breast budding that's occurred and some pubic hair growth, although you probably could count the hairs if you needed to. Tanner stage 3 is further progression. At Tanner stage 4, the breasts have a very typical appearance of a mound on a mound. So the areola is separate and distinct from the remaining breast tissue. By Tanner stage 5, the breast has achieved an adult contour where the areola and the remaining breast tissue are confluent. In terms of a genital exam, I like to tailor the extent of my exam to the problem at hand and try to make it appropriate for the individual patient. So every patient should have at least an external inspection of the genital area. This provides you with information about whether there's clitoromegaly, whether there's an appropriate hymenal opening, and gives you a chance to assess whether there's been any estrogen effect on the hymen and anterior vagina. Does the patient have the same beefy, red, and dry appearance of a prepubertal young child, or does the patient's vagina have the appearance of healthy, pink, moist tissue as you would expect for an adolescent who's gone through puberty? We also often try to do some assessment of the internal reproductive structures, specifically focused on whether the vagina is patent and appropriately long. This can be done using a tiny metal Calci swab just to determine that the vagina is an appropriate length. A one-finger examination is often tolerated, which allows palpation of the cervix. And a speculum exam would be appropriate for sexually active teens. If you're not able to conduct any kind of internal exam, a pelvic ultrasound may be helpful to confirm the patency and the presence of all of these structures. And what we're looking for with the internal exam are any of these congenital blockades that can prevent normal vaginal bleeding. So a transverse vaginal septum is a wall of tissue that forms during embryologic development, and that can occur at many different levels of the vagina, and that can be a full blockage or partial blockage. So some patients may have some menstrual blood flow occasionally or primary amenorrhea and no menstruation at all. The imperforate hymen is often picked up in the newborn nursery, but we do see adolescents where this has been missed. And as you can see there, the hymen usually is quite stretched out and bulging because of the retained blood behind that hymen. In a truly imperforate hymen, the vagina is not visible, even with gentle retraction of the labia, as opposed to a septate hymen where there may be a band between, but vaginal tissue is visible behind that hymen, and typically menstruation can occur, although tampon use may be difficult. Vaginal agenesis occurs in 1 in 5,000 female births, and this syndrome is associated with the absent or incomplete vagina. Often it also has a small or absent uterus, but it's important to remember that these are genetic females with normal ovaries. On physical exam, we're also looking for signs of androgen excess, so specifically looking for excess terminal hair growth in an often male pattern and acne as well. In order to quantify the extent of abnormal hair growth or hirsutism, we recommend using a tool like the Ferriman-Galway score so that you can determine whether this young woman has clinically significant hirsutism, and it gives us a way to track improvement over time. So each of these body sites is rated from a 0, no hair whatsoever, through 1 to 4, which is the presence of some terminal hair growth in these areas. Hirsutism is indicated by a score greater than 6 to 8, depending on which reference you use. We also look for Acanthosis Nigricans, which is thickening and darkening of the skin, typically occurring in flexural areas, such as the back of the neck or in the axilla. And then true virilization is rare, but would occur in certain cases, such as tumor, and we would see more of a very male pattern of chest hair growth and clitoromegaly. We recommend measuring the clitoral width as opposed to clitoral length because it's easier to reproduce those measurements over time. So the next important question becomes, what tests do we order, and how do we focus our evaluation to determine where things may be going wrong? Much of this is influenced by the history we've obtained, as well as findings on exam and through review of the growth charts. So coming back to our ideas about where problems occur, we can look to determine what labs we should get. So in order to evaluate the hypothalamic pituitary axis, we recommend getting an FSH, possibly LH, a prolactin level, and maybe a blood count if you're worried about chronic disease. A TSH and free T4 are helpful to evaluate the thyroid gland function. To look at the ovaries, we recommend an estradiol, plus or minus testosterone, both total and free, if there's signs of androgen excess. Similarly, depending on your physical exam and history, you may want to get a dehydroepiandrosterone steroid, DHEAS, a urinalysis, or a 17-hydroxyprogesterone in order to evaluate the adrenal glands and look for evidence of congenital adrenal hyperplasia. And always in adolescent medicine, everyone gets a pregnancy test. Other laboratory studies that may be indicated based on your history and exam could include a SED rate or a chemistry panel if you have concerns about chronic illness or eating disorders, growth factors if you're concerned about slow growth, celiac screen for patients with poor weight, GI symptoms, fall off in height. If you have a patient with an elevated FSH, an indication of ovarian dysfunction or failure, a karyotype can be very helpful. And for girls with signs of androgen excess or whose evaluation appears to be pointing toward polycystic ovary syndrome, a hemoglobin A1C or fasting lipids could be an important part looking for the metabolic consequences of that syndrome. So when studies have been done looking at causes of primary amenorrhea, this is a study done by Richard Reindaller back in the 80s. And of these over 250 patients, premature ovarian insufficiency was very common in their sample, accounting for 50% of their patients. That was followed by hypothalamic hypogonadism, Mullerian issues, outflow obstructions, pituitary disease, and then a small cohort consisting of androgen insensitivity, congenital adrenal hyperplasia, or PCOS. Looking at secondary amenorrhea in a more recent study, ovarian disease, either premature ovarian insufficiency or polycystic ovary syndrome, accounted for 40% of girls. Hypothalamic dysfunction was another 35%, and then pituitary disease or uterine issues counted for the remaining girls. So when we're working toward a diagnosis, I think much of our decision-making can be based on the FSH and LH levels, and whether those are low, indicating hypogonadotropic hypogonadism, normal, or high, indicating hypergonadotropic hypogonadism. So in patients with low LH or FSH levels, but normal secondary sex characteristics in normal appearing genitalia, we're typically looking at hypothalamic or pituitary issues. So endocrinopathies, stress, the female athlete triad, or eating disorders, either anorexia or bulimia, other chronic illnesses such as diabetes, GI diseases, medications, particularly those that can cause hyperprolactinemia, or physiologic delay. Some girls are just late bloomers. In addition, we're looking at pituitary disease, infiltrative processes, tumors, or sequelae of head injuries. If you have a patient with low FSH or LH, but no secondary sex characteristics, you should think about Kallman syndrome in that scenario. Then again, the opposite, looking at our patients with high LH or FSH levels and normal genitalia, that indicates ovarian insufficiency. The brain is trying its best to tell those ovaries to work, and they're not responding. It's a primary ovary issue. Again, that can occur with gonadal dysgenesis, such as with Turner syndrome. It's a common sequelae of chemotherapy or radiation therapy to the pelvis. Autoimmune ovarian disease. It's also associated with galactosemia, trisomy 21, and Fragile X premutation carriers. And then lastly, with a patient with normal gonadotropins, normal secondary sex characteristics, normal appearing genitalia, pregnancy, 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 polycystic ovary syndrome, thyroid disease, issues with the adrenal glands, or rarely uterine causes, but these are quite rare in the adolescent. And then lastly, patients may have completely normal hormone levels, but just abnormal genitalia. And again, these are those anomalies of the reproductive tract. So congenital anomalies of the hymen, the vagina, cervix, or uterus, vaginal agenesis, including MRKH syndrome, androgen insensitivity, or 17-hydroxylase deficiency with 46XY chromosomes. Often imaging studies may be helpful to point us in the direction of one diagnosis or another. So as we mentioned previously, a pelvic ultrasound can be helpful for patients in whom the physical exam is limited, or for those patients who you really feel it's important to determine how the uterus and ovary have been developing. The one caveat there is that if your pelvic ultrasound is performed at a center that typically sees adults and so has more experience seeing women with very large pregnant uteri, they may not be as experienced in seeing smaller uterus and ovaries, such as would occur with prepubertal children. So we often will get reports, panicked reports, from studies saying cannot visualize the uterus or cannot visualize ovaries. That may not mean that these structures are not there. It's just that the radiologist may not realize quite how small they are in these prepubertal or early pubertal girls. Similarly, multicystic ovaries are very common at this age. That can be a common sequelae of anovulatory cycles and does not always indicate polycystic ovary syndrome in an adolescent. Quite a few normal girls will have multicystic ovaries. If you find a mass or a Mullerian anomaly, the kidney should also be scanned because there's many renal anomalies that are associated with Mullerian anomalies. If you're truly concerned about an obstructive process of the uterus or vagina, an MRI is more helpful for determining at what level the obstruction has occurred and what structures are present. A bone age or wrist X-ray can be very helpful in determining where in puberty the patient is, particularly if growth has been interrupted over time or if you're interested in seeing the patient's potential for future growth. CNS imaging is important for specific indications. So girls who've had interrupted puberty, they started out normal and then have petered out. Patients that have neurologic signs or symptoms, or girls with a consistently elevated prolactin all deserve CNS imaging, typically with MRI. In terms of management, the treatment options for these patients truly depend on the underlying etiology, and the goals of therapy vary. For patients who've not made it successfully through puberty, our goal is to develop gender-appropriate sexual characteristics. So ensure that a girl has had adequate breast development, hair development, and growth of her uterus. We want to ensure both uterine and endometrial health. Girls who aren't menstruating regularly, but who are producing normal levels of estrogen, are at risk for endometrial hyperplasia. That's problematic in terms of future risk of endometrial cancer and because it's a setup to have overgrowth of that uterine lining, which could cause dysfunctional uterine bleeding. We're concerned about bone health. Girls in their adolescence should be making healthy levels of estrogen to promote appropriate bone mineral accrual during this small window of time for bone development. Also, estrogen is important for both cardiac health and future reproductive health. One option for early management, both in terms of diagnosis and treatment for preventing endometrial hyperplasia, is a progestin challenge. Administering a form of progestin for 10 days will induce a withdrawal bleed within 10 to 14 days of stopping the therapy. In terms of diagnosis, that allows the practitioner to know that the patient's been making sufficient estrogen to grow that uterine lining. Otherwise, there's no withdrawal bleed because there's been no lining developed or because there's an obstruction that's preventing normal blood flow. It also is good treatment, again, to keep that uterus healthy. For girls that have normal estrogen levels, the goal is to shed the endometrial lining on a regular basis to prevent hyperplasia or abnormal uterine bleeding. And this can be accomplished by using oral progestin for 12 to 14 days every 1 to 3 months, or using combination estrogen products such as oral contraceptive pills, the transdermal patch, or the vaginal ring. For patients who have low estrogen levels, the treatment is different, and the goal here is to help the patient to restore the appropriate hormonal milieu for their age. So if they're an athlete, they may need to decrease their training in order to allow their body to have sufficient energy to move it toward hormone production. If they're underweight, they need to increase typically to at least 90 to 92% of ideal body weight or median body weight, and any underlying eating disorder should be addressed. Girls, particularly who have low estrogen therapy, already have a risk factor for low bone density, and so ensuring that those girls are consuming adequate calcium and vitamin D is important to make sure we're promoting their bone health in any way we can. There's many options for estrogen replacement therapy when that is needed, such as in cases of premature ovarian insufficiency. It can be done with conjugated equine estrogens, transdermal 17-beta estradiol, micronized estradiol, which is given orally, or oral contraceptive pills. For estrogen replacement therapy, that is monotherapy, so the first 3 options on that list, it is important to, again, cycle with progestins every 1 to 3 months to prevent that unopposed estrogen secretion. And for many of these girls, it's also important to give them some counseling about their reproductive potential. So girls who have premature ovarian insufficiency at age 16 are much less likely to be able to have a successful pregnancy with their own eggs in the future. And it can be important to let patients know about this and have them seek fertility treatment early on, or to be able to plan appropriately for their future. So now I'd like to go through a few cases to highlight some of the information that we've gone over today. So case number 1 is Maria. And Maria is a 15-year-old girl who comes into clinic with a complaint of having had no periods for the last 4 months. She had pretty normal pubertal development. She'd had breast development around age 10, and menarche occurred at age 11 spontaneously. She's otherwise pretty healthy. She's been seeing a dermatologist because of some acne and for laser hair removal on her face. And she says she's always struggled with her weight, but particularly around the time of puberty. Her past medical history is significant for her being small for gestational age at birth, but she's otherwise been well. And in terms of family history, all she knows is that mom had some difficulty getting pregnant, but she doesn't know why or have any other information about that. So on her exam, her BMI is 29, and you notice some skin darkening and thickening over her neck, excess hair on her chin, over the sideburn area, on her lower back and lower abdomen, and she's got moderate papular acne on her face and her upper back. And on her general exam, her vaginal mucosa appear very well estrogenized, and there's no clitoromegaly present. So you send off some lab work for Maria, and you get back pretty normal FSH and LH levels, a normal TSH and prolactin. Her DHEAS is 267, which is in the normal range at our institution. She has both an elevated total and free testosterone above the normal range and a slightly low sex hormone binding globulin. So Maria would meet the diagnostic criteria for polycystic ovary syndrome. And in 2014, it's pretty confusing to know which criteria are appropriate to use. So in 1990, the NIH developed criteria for the diagnosis of polycystic ovary syndrome. And they determined that patients needed to have anovulation or oligoovulation, as well as clinical or biochemical hyperandrogenism. In 2003, a group of experts got together in Europe and developed the Rotterdam criteria. And with the Rotterdam criteria, they determined that in order to be diagnosed with PCOS, girls had to have anovulation or oligomenorrhea, hyperandrogenism, or polycystic ovaries on ultrasound. And patients only needed 2 out of these 3 criteria in order to get diagnosed with polycystic ovary syndrome. Well, this was felt to be problematic by many groups because what this allowed, for example, was girls to have irregular infrequent periods and abnormal ovaries on ultrasound without any signs of hyperandrogenism, either by physical exam or by laboratory studies, and still be diagnosed with polycystic ovary syndrome. Or it allowed girls to have regular periods, but hyperandrogenism clinically and abnormal appearing ovaries on ultrasound. So in 2006, the Androgen Excess Society formed to develop their own diagnostic criteria, and they determined that PCOS, in their viewpoint, was primarily a disorder of androgens. So therefore, hyperandrogenism was essential. And you had to have either clinical or biochemical evidence of hyperandrogenism, as well as a sign of ovarian dysfunction. And that could either be anovulation or abnormal ovaries by ultrasound. In adolescence, the diagnosis is particularly challenging because during that first 1 to 1.5 years following menarche, anovulation is very common. Most girls during that time frame don't have regular cycles. However, the persistence of anovulation for more than 2 years is a very strong predictor of continued irregularity happening in adulthood. Additionally, in adolescence, polycystic ovary syndrome can present as primary amenorrhea. In a large series of adolescent PCOS done in our clinic, almost 9% of girls had primary amenorrhea as their presenting symptom. And also, there's very little normative data on androgen levels during adolescence. Most of the lab ranges that we use are based on adults. So what happens in PCOS is the opposite of what's happening in a normal menstrual cycle. So typically, in a normal menstrual cycle, the pituitary hormones FSH and LH travel along. They peak around day 14 of a typical cycle, and ovulation occurs. With polycystic ovary syndrome, you have static elevation of LH and FSH. They don't cycle typically, so there's no stimulus for ovulation to occur. When we're thinking about polycystic ovary syndrome, we think about getting many of the same laboratory studies that we talked about when talking about amenorrhea. So FSH, LH, prolactin, and TSH, looking at the androgens themselves, so testosterone, free testosterone, sex hormone binding globulin, and DHEAS. We often will get fasting lipids, as well as some measure of insulin resistance, which is also a common part of this syndrome, although not part of the diagnostic criteria. And that can be done through a fasting insulin and glucose level. It can be done with a full 2-hour oral glucose tolerance test, and it can be done through a hemoglobin A1C. The guidelines all recommend getting a morning 17-hydroxyprogesterone to rule out late-onset congenital adrenal hyperplasia, which can have a very similar clinical picture to polycystic ovary syndrome. And a pelvic ultrasound can be helpful for patients in whom need a little more evidence one way or another to point you to or away from the diagnosis. The treatment goals for PCOS are to manage those irregular menses, to decrease hirsutism and acne for patients, to improve the patient's quality of life, to increase insulin sensitivity, and to try to prevent the long-term complications of this syndrome, which include the development of diabetes, fertility issues, endometrial hyperplasia, and cardiovascular disease. So when we're targeting our therapy, I typically try to focus the patient on what they're most worried about. So if my patient is concerned about their lack of regular periods, my first-line therapy is likely to be a combined estrogen-progestin product, maybe second-line metformin or progestin. If my patients are most concerned about hirsutism, again, a combined estrogen-progestin medication is typically our first-line therapy. Spironolactone or removal can also be very helpful. If weight and insulin resistance are the biggest concern, lifestyle change remains the cornerstone of therapy as it is for all weight-related conditions, but metformin can also be helpful. And infertility is typically not a concern for most of my adolescent patients in whom I'm trying to prevent pregnancy. So lifestyle change, again, is the hallmark of all therapies. And weight loss in this syndrome decreases androgen production, improves insulin sensitivity, and reduces cardiovascular risk. And this can occur with as little as a 5 to 7% decrease in body weight. This does not require changes of multiple pounds in order for the patient to see a positive difference. And we often recommend a healthful diet, moderate physical activity, and of course, smoking cessation. The estrogen-progestin therapy works in many different ways. First of all, estrogens increase liver production of sex hormone-binding globulin. So that helps to decrease the amount of circulating free testosterone. The testosterone becomes bound to the sex hormone-binding globulin, and it can't exert its effects on the skin or hair follicle. Estrogen treatment also decreases ovarian and adrenal production of androgens. So you've also stopped the overproduction at the source. It does not cause any changes in insulin sensitivity. In terms of the best pill choice, anything is better than nothing. Sometimes we will tell practitioners to try to avoid more androgenic progestins, and for more obese patients, you might get better control of the ovaries with use of a 35 microgram ethinyl estradiol pill as opposed to the lower doses. For some girls as well, we debate cyclic pills, so where the girl is having a period every month, versus continuous pills where she's skipping the placebo week to prevent periods. Continuous pills can be helpful for girls who end up with a flare in their acne during every placebo week. That means then the girl's flaring for a week with her acne, taking another week to get her acne under control, and doesn't have much time where she's feeling pleased with her skin. Continuous pills can help to prevent that flare from occurring. Menses can be regulated with cyclic progestin therapy also for patients who have contraindications to estrogen. And we typically use progestin for 12 to 14 days every 4 to 8 weeks, and there's multiple methods of delivering that medication. Progestin will help to keep the uterus healthy. It maintains endometrial health, but it does not lower androgen levels. So patients will not see an improvement in their acne or hirsutism. Anti-androgens can be helpful as well in terms of treating acne and hair growth. Spironolactone is the one that is FDA approved in the United States. It's not 100% effective. Somewhere around 40 to 60% of patients see improvement at 12 months. These have to be used with some form of birth control because they are teratogenic. So they're best used with combination oral contraceptive pills. Additionally, spironolactone often causes irregular bleeding, so having your patients on something to regulate their periods is important. The dose ranges from 50 to 100 milligrams once or twice a day, and side effects are related to spironolactone's very mild diuretic effect and typically improve over time. We also commonly use metformin for treatment of polycystic ovary syndrome, particularly in girls who have demonstrated insulin resistance. Metformin works to suppress gluconeogenesis in the liver. It helps move glucose into cells, and it increases peripheral insulin sensitivity. So it helps to lower androgens, decrease body weight, improve blood pressure, and lower LDL levels. In many patients treated with metformin therapy alone, menses will resume. This happens in 60 to 96% of patients, but the effect on hirsutism is fairly limited. Metformin's also been nicely demonstrated to slow the progression to type 2 diabetes. We start with a low dose of metformin and titrate up to a typical goal of about 1,500 to 2,500 milligrams daily. There's extended release forms, which are nice for adolescents because they allow once-a-day dosing and may be associated with less GI symptoms, which include flatulence, diarrhea, and nausea. Metformin can interfere with vitamin B12 absorption and levels can decrease, so we recommend our patients use a multivitamin if taking metformin. Metformin is contraindicated with renal or liver failure, and it should be discontinued prior to procedures that put the patient at risk of dehydration or kidney problems because of a risk of lactic acidosis in that situation. We have our patients discontinue metformin prior to surgery, before they're going to get IV contrast, or if they're at risk to become dehydrated. Metformin is also contraindicated in the presence of heavy alcohol use, which is important for many of our adolescent and young adult patients to know. So back to our case, Maria starts her birth control pills and she tolerates them well. She continues to gain weight though, and so we added metformin to her medication regimen a few months later. She missed a follow-up visit, and so she doesn't come back to clinic for another 6 months. And when she sees us, she reports that she hasn't had her period for another 2.5 months. And she shares that she came off the birth control pills because her friends convinced her that the pill was what was causing her ongoing weight gain. So she stopped her birth control pills, but she continued with her metformin because she perceived that the metformin was going to help her lose weight. And Maria's pregnancy test in clinic was positive. This is related to that mention I made of metformin improving menstrual cycles and ovulation all on its own. So this study was performed by Dr. Ibanez in Spain, and she took 18 adolescents who had polycystic ovary syndrome and were anovulatory. And so you can see here, 0% of these patients were ovulating. She started them on a reasonable dose of metformin, and within 6 months of metformin monotherapy, over 80% of those girls were ovulating just with metformin alone. So this is important to let our patients know they are at risk of pregnancy when using metformin monotherapy because ovulation often resumes. And just thinking again about polycystic ovary syndrome complications, during adolescence we worry about the irregular periods, hirsutism, acne, obesity, and quality of life. As we move into the reproductive years, infertility, hypertension, and diabetes become problematic. And then moving from the reproductive years into the postmenopausal years, we also start to be concerned about cardiovascular disease as well as endometrial cancer. So proper treatment for these girls is really essential because their disease is associated with so many other comorbidities. So case number 2 is Kaitlin. Kaitlin is a 14-year-old female with primary amenorrhea. She had breast development around age 11 and a half, but nothing since. She's a picky eater. She describes herself as a vegetarian. She likes dance. She takes lessons. She does competitions on the weekends. On her exam, her BMI is 15.7, which places her at about 81% of her ideal or median body weight. Her breasts are present, but they're small. They're around a Tanner stage 3. Her vaginal mucosa on exam is very dry and reddened, and her vaginal canal is a normal length to your Q-tip probe. Here is Kaitlin's growth chart. And what I see looking at Kaitlin's growth chart here is, number one, a real drop in her weight around age 11 to 12 with a slow increase back up toward the curve, but really this big shift there. And around that same time, this shift over in her height, where she's crossed over many growth percentiles. She's still growing, but there's definitely this shift down from where she was before. So we send some laboratory studies on Kaitlin, and we see that her FSH is only 2. Her estradiol is less than 10, so below the measurable level in our lab. Her white count's on the low side. Her sed rate's 3. Her chemistries are normal. TSH is normal with a low T3, which is consistent with a malnutrition. Pretty much everything looks consistent with her malnutrition. Kaitlin started to see a therapist weekly. She had monthly nutrition visits and close medical follow-up. A DEXA done to assess her bone density was fortunately normal. She increased her calcium and vitamin D intake, and she eventually reached a weight about 94% of her ideal or median weight, and then spontaneously had menarche. And what studies have shown in terms of resumption of menses is that this goal weight of about 90 to 92% of median body weight is associated with resuming menses sometime within 3 to 12 months after achieving that goal weight. Many weight-recovered patients with anorexia will continue to have abnormal menstrual cycles, even when they've restored an appropriate body weight. In this nice study indicated, it looked at girls with anorexia and control subjects who never had troubles with eating. They were very similar in terms of age, and at this point, they had no difference in their BMI. The difference between these girls who were recovered anorexics with amenorrhea versus controls who were menstruating normally was this eating disorder inventory, which is a self-report scale of struggles around weight concerns, eating habits, preoccupation about weight, exercise, calories. And the girls who had recovered their weight from anorexia continue to struggle with the psychological aspects of their eating disorder as opposed to the control subjects. And it's really this ongoing stress that is related to the lack of regular periods. Another study done of over 2,500 high school girls showed that frequent binging and purging was the #1 risk factor for secondary amenorrhea, more than weight changes, weight loss, smoking, or being within the first year after menarche. So case number 3 is Gina. Gina is a 13-and-a-half-year-old with a chief complaint of no menses ever, so primary amenorrhea. She's active in sports, she eats well, nothing else is bothering her. She had breast buds at age 11 and then some scant pubic hair. Her mom is 64 inches tall, her dad's 69 inches tall, and she's 62.5 inches tall, so a little shorter than we might expect. Her BMI is 15.3. Her breast and pubic hair are at standard stage 2, so giving you some sense that puberty really did start, but then seemed to halt. And her external genital appear pretty normal. Her rectal exam was normal, etc. So here is Gina's growth chart, and what I see on her growth chart, again here, is this weight really being stagnant over several years, and associated with a year or two after weight dropped off, this drop in her height, again where she's crossing growth percentiles instead of continuing to grow where she was along her growth chart. So her laboratory studies show a CBC with a slightly low hematocrit, but she has normal sed rate, normal chemistry panel, a bone age that's a bit delayed, consistent with her lack of ongoing pubertal development, and other things look pretty normal. However, her celiac panel came back positive. She was treated with a gluten-free diet and resumed normal growth and development. And what you see here is that when she started her gluten-free diet, look at her weight very nicely going up, as well as luckily some further increase in height back up to where she was before. So a happy ending to that story. Case number 4 is Kristen. So Kristen is a 17-year-old who also has primary amenorrhea. So she started puberty at age 10, but had no further development after age 12. She's never had any bleeding. She doesn't have any normal vaginal discharge. She's a vegetarian, but she denies any kind of weight loss, denies any kind of GI symptoms. She says she has migraine headaches around 2 to 3 times a week. She was seen by a neurologist back in 9th grade and given some treatment for when she had headaches. And she's a 12th grader, an A student. Everything else is really together. So on her exam, she's a normal weight and height and normal vital signs. She has small Tanner 3 breasts, and her pubic hair is Tanner stage 3 to 4. And on her external genital exam, you notice a normal vagina and uterus that you can palpate, but maybe diminished estrogen effect on her vaginal mucosa. Here is her growth chart. And again, I think you can see here kind of this lack of growth after age 12 or so. To get some studies, and her bone age was 14. She had normal thyroid tests, low gonadotropin, and her prolactin was 13,000. The normal range is less than 18. She had CNS imaging performed, which showed a pituitary and suprasellar tumor. She was treated with cabergoline, increasing doses to get that prolactin under much better control. Her prolactin levels fell back toward a normal range, down to 45 to 75, so couldn't get her all the way down there, but improvement. And as her prolactin fell, her estradiol came up. With the spontaneous improvement in her estradiol, her breast development occurred, and she had 3 spontaneous menses during her 2nd year of treatment. So again, restoring at least some of her reproductive health there. So in terms of take-home points, what I want to remind people of is that amenorrhea may be a presenting sign of a very serious illness, as was the case for our last patient who had the tumor, as was the case for the young woman with celiac disease, as was the case for the young woman with an eating disorder. Many people think of menses as another vital sign for young women, that a period, yes, no, whether it's regular, yes, no, is just as important as their blood pressure and heart rate for assessing their overall health. The history and physical exam truly provide more than 95% of the diagnostic information in almost all cases. And the laboratory studies or radiology studies are done as an adjunct to that to hone your diagnostic impression one way or the other. The treatment for amenorrhea truly depends on the other underlying etiology. Sometimes it involves hormonal therapy. Sometimes it involves treating the underlying disorder. But the goal in all cases is to resume the normal hormonal milieu so that all the systems in the body that are affected by estrogen and androgens remain in good balance, and to establish regular menses.